Assalamu alaikum and good evening to you all. Welcome to the Health Talk on Acute Medicine, organized by SCB Bangladesh Chapter and supported by Bangladesh Society of Medicine. Today, we have come to the 8th episode of our Acute Medicine series. On this episode, we are going to talk about another very important topic. Today's topic is acute management for myocardial infarction. To talk about this important topic, we have the talented Professor Abdul Wadud Chowdhury sir himself. He is the professor and head of the Department of Cardiology, Dhaka Medical College. To chair the session, we have our very own Governor of SCB Bangladesh Chapter, Professor H.A.M. Nazmul Ahasan sir. He is the former president of Bangladesh Society of Medicine. As a panelist, we have two most renowned professors of our country. Firstly, we have Brigadier General Professor M.D. Abdur Razzak sir. He is the APLAR Fellow of Pneumatology and Chief Physician General, CMH, Dhaka. We also have Professor M.D. Mahabubul Islam Majumder sir. He is the head and professor of medicine, Central Medical College and Hospital, Kumilla. To moderate today's program, we have Dr. Pankaj Kanti Datta sir. He is the Assistant Professor of Medicine, Dhaka Medical College. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Pankaj Kanti Datta sir. Dr. Pankaj Kanti Datta sir.
Dear viewers and listeners, to today's health talk, we have a very important topic today: the acute management of myocardial infarction. And as you know, we have the master speaker today, Professor Muhammad Abdul Wadud Chowdhury. He is a professor and head of the Department of Cardiology, Dhaka Medical College. And we have a chairperson, none other than the governor of SCB himself, Professor H.A.M. Nazmul. And we have two distinguished panelists today, Brigadier General Professor Muhammad Abdul Razzak and Professor Muhammad Mahabubul Islam Majumder sir. So we have a very good topic to discuss today: the myocardial infarction. It is an emergency condition, and in this context, we know minute means muscles. So we have to act promptly so that minute doesn't mean morbidity and mortality to the patient, or minute doesn't mean the memory of death of a patient to their relatives. So without further talk, I like to go straight away to the speaker. I'm humbly requesting Professor Abdul Chowdhury sir to go on with his speak today. Thank you.
Thank you, Dr. Pankaj. Assalamu alaikum and good evening to everybody. I'm really grateful to one of my mentors, Professor H.A.M. Nazmul Ahasan. I was his student, and he's one of the person whom we took as an idol. We wanted to be like him in knowledge, in expertise, in temperament, in the ability to teach, to guide. And I'm really privileged that today he's going to chair the session. Ladies and gentlemen, today I'm going to talk about acute management of myocardial infarction. I'll be using both English and Bangla as the lingua franca. MI, commonly known as a heart attack, is defined pathologically as the irreversible death of myocardial cells caused by ischemia. Look at it. It doesn't mean that you have to have a huge amount of muscle death. Small amount of muscle death is also MI. Clinically, myocardial infarction is a syndrome that can be recognized by a set of symptoms, chest pain being the hallmark of the symptoms in most cases, supported by biochemical laboratory changes, electrocardiographic changes, or findings on imaging modality like echo, to detect myocardial injury and necrosis. We use the term acute coronary syndrome. What does that mean? It's a spectrum of conditions that occur due to acute myocardial ischemia and or infarction as a result of an abrupt reduction in blood flow through the coronary circulation. That could be non-ST elevation acute coronary syndrome, which is further divided into unstable angina or non-ST elevation MI. The difference is being one have the biomarker elevated, another is not, and also the ST elevated MI. The major discriminating feature of which is the presence of symptoms of myocardial ischemia along with persistent ECG ST segment elevation. Why that is important? Because the treatment approach in these two sets of syndromes are a little bit different with different outcome if we do not follow through. Let's go a little bit into epidemiology. We do know the cardiovascular disease are the leading cause of death globally. How much? Coronary heart disease is alone responsible for over 15% of mortality each year. And if you consider the cardiovascular disease as a whole, it represents 32% of all global deaths. And among that, 85% are due to acute heart attack and stroke. And the most important thing is, over 3/4 of these deaths occur in low and middle income countries. We are in that group. And if we consider that, as who suggest, if we die under the age of 70, it's premature. 17 million premature deaths occurred due to non-communicable disease in 2019, of which nearly 40% are caused by cardiovascular disease. If you consider SCS in developing countries between STMI and non-STMI, the Indian registry shows STMI 61%, non-STMI 39%. Global registry suggests the other way around. European Heart Survey shows around 42% STMI, 51% non-STMI. Why is the difference? That means a huge lot of non-STMI are not diagnosed in Indian diaspora. We should remember that. And what is the mean age? Look at the Indian registry. The mean age is 57 years. Globally, it is 64 to 69. European Heart Survey, 63. Do you know what is the first age of average first age of heart attack in this country? 51 plus, 51 or 52. Among the countries belonging to this Indian subcontinent, we have the youngest patient group who have MI at an earlier age. And the Nepalese have the eldest group. They have around 55 or more, the first MI. And how much primary PCI, which is the hallmark of effective treatment for MI, available? In India, it's around 8% or 7%. In our country, in a busy hospital where the primary PCI is available, only around 6% can avail of that opportunity. If we consider the whole context of Bangladesh, it's less than 1%. And is it important, the differentiation between STEMI and non-STEMI? Yes. 30-day mortality in STEMI, 9% versus 4%. Acute death is more in STEMI. But if we consider the same thing after a year, you'll be surprised to find out that survivors of non-STEMI are dying more than the survivors of STEMI. If you consider the etiology, we know it. 90% of MI occur from an acute thrombus that obstructs an atherosclerotic coronary artery. Why? There is plaque rupture and erosion that ogles out the materials in a plaque, which are very much thrombogenic. Following plaque erosion or rupture, there is platelet activation and aggregation. There is activation of the coagulation pathway. There is endothelial vasoconstriction. All these lead to coronary thrombosis, occlusion, MI, and many times death. Universal definition of MI was established to make a uniform nomenclature. What do you mean by MI? Detection of increase and or decrease of cardiac biomarkers, preferably high-sensitive troponin T or I, with at least one value above the 99th percentile of the upper reference limit. And that's the important thing. In this context, there should be one of the following: either symptoms of myocardial ischemia, or there should be new ischemic ECG changes, or there should be development of pathological cue, or we can show in imaging there's loss of viable myocardium or new regional wall motion abnormality in echo. Or if you do the angio, there we can find a thrombus, or if the patient die, autopsy can show a thrombus. Look at this. Why this difference? Previously, it was the symptom plus ECG change which was important. Now we are saying paying much more attention to cardiac biomarkers, because non-STEMI, where ECG changes may not be there at all, may present only with increase in the cardiac biomarkers. They have increased mortality and morbidity, but you may not find anything wrong with the ECG. So the symptoms and the biomarkers, these are important. A little bit about the types of MI. Why am I saying that? Because in the COVID era, we will be hearing a lot about type 1 MI, type 2 MI, etc. What do we mean by that? Spontaneous myocardial infarction due to atherosclerotic plaque rupture, ulceration, fissure, or erosion. That's type 1 MI. Mind it that both STMI and non-STMI belongs to type 1 MI. What about type 2 MI? There is an imbalance between myocardial oxygen supply and demand. A very anemic patient undergoing a stressful situation or workload may have an MI resulting in increase in troponin I. There may not be any ECG changes, but there's type 2 MI because there is huge mismatch between the oxygen supply and demand. That resulted in necrosis of some of the myocardial cells. Type 3 MI, where the patient is already dead, biomarkers not available, but later on autopsy or other findings suggested the patient has died of MI. Type 4 MI related to PCI, type 5 MI related to CVG. So we'll be concentrating our talk mostly on type 1 and type 2 MI. What is the criteria for type 1 MI? The most important thing is troponin I or troponin T rise with, as I have already mentioned, the definition of MI actually define type 1 MI. Look at this. The picture shows there is a plaque rupture and erosion that leads to the atherogenic materials inside the plaque that comes in contact with blood that lead to activation of the coagulation pathway that leads to platelet aggregation and activation, whereby a occlusive thrombus is developed. There may be non-occlusive thrombus, there may be occlusive thrombus. And even with occlusive thrombus, the patient may have only a non-STMI because that area is already getting some blood supply from elsewhere by collaterals, or even with a non-occlusive thrombus, patient may have a full-blown MI, ST-elevated MI. So pathological manifestation and the ECG changes, ST elevation or non-ST elevation MI, are not synonymous always. What about type 2 MI? We have a rise and fall of troponin, but there is an evidence of imbalance between myocardial oxygen supply and demand, which is not related to coronary atherosclerosis. There may be that it requires at least one of the following: the symptoms of acute myocardial ischemia, or ischemic ECG change, or pathological Q wave, or imaging evidence of new loss of viable myocardium, or wall motion abnormality. Look at this one. There may be spontaneous dissection or there may be intramural hematoma due to trauma. There may be coronary spasm. There may be coronary embolism. That may be infective origin, or that may be from a calcific valve. Aortic dissection can also lead to coronary artery or ostial occlusion. And because of the hematoma, because of the flap. And that can lead to an MI. And type 2 MI, there is vasospasm or microvascular dysfunction or non-atherosclerotic coronary dissection or oxygen supply demand, all this leading to this. And what are the common causes? Cardiac causes, tachyarrhythmia. Atrial fibrillation's fast ventricular rate can lead to raised tropi, but that's type 2. Bradyarrhythmia, because the heart rate is so low, the output is so low, the blood pressure falls down, and the heart is not getting enough blood. Severe aortic valve disease, HCM, acute heart failure, coronary vasospasm, coronary vasculitis, and spontaneous coronary artery dissection. All these are causes of type 2 MI. Systemic cause like hypertension alone, very raised blood pressure can lead to raised tropi, some injury of the myocardial cells without type 1 MI. Non-cardiac surgery, critical illness, septicemia, shock, hypoxia, particularly respiratory failure, all this can lead to raised tropi. The important thing is you treat something with taking the patient to the cath lab and opening up the artery. In other time, the type 2 MI, you have to treat the underlying cause. That's the treatment. Now, STEMI, which belongs to type 1 MI, how do I define it? Persistent chest discomfort or other symptoms suggestive of ischemia, and ST segment elevation in at least 2 contiguous leads. The universal definition and ESC guidance suggests more than 20 minutes. SSC, American College of Cardiology, AHA suggests more than 30 minutes. But as a whole, whenever it's more than 20 minutes, it's most likely MI. The persistent chest pain can radiate to the neck, lower jaw, and left arm. Less typical presentation could be shortness of breath, nausea and vomiting, fatigue, palpitation, or patient may have only syncope. And ECG shows the patient already had an inferior MI. There is complete heart block, severe bradycardia, and that's why he had a syncope. But chest pain may not be there. Diagnosis is based on clinical feature, classical ECG changes, and raised cardiac biomarkers. The ECG criteria include new ST elevation at the J point in at least 2 contiguous leads. If, in case of men, the less than 40 years of age, in anterior chest leads, there should be more than 2.5 millimeter. But in limb leads, it's more than 1 millimeter. That ST elevation is important. But V2, V3, you have to have more than 2.5 or more elevation to consider it MI. If you are more than 40 years age, 2 millimeter or more elevation in V2, V3, or if you consider the other leads, 1 millimeter or more, suggest you have MI. In case of women, the degree is more than 1.5. Right-sided ECG, when we consider the RV infarction, the ST segment elevation significant point is 0.5 millimeter. But in case of young men, there should be more than 1 millimeter. In case of posterior MI diagnosis, the cutoff point is 0.5 millimeter elevation. And how do we assess it? The arrow 1 indicates the onset of the Q wave. Arrow 2 indicates the onset of the ST segment or J point. It's the end of S wave or QS complex and 80 milliseconds beyond that. That's the J point. That's why we should consider assess the ST segment level. The difference between points 1 and 2 denotes the magnitude of the ST segment elevation. what is the baseline from where we should consider this much elevation of ST segment is present? That is the dead point. The first point where the QS complex starts. From that point, how much elevation is there? That is the level by which we assess this much ST segment elevation is present. There will be different types of ST elevation. Look at the first blocks. Look at the ST elevation types. All these ST elevation are important, but you should always consider the clinical context. What is the presentation of the patient? There could be convex or upsloping or horizontal or downsloping, but ST segment elevation is there. And the lower panel actually shows different types of changes which occurs with time. Normal ECG, hyperacute T wave that can occur from minutes to hours. There is ST elevation within 12 hours. There is Q wave development within 1 to 12 hours. There is ST elevation with T wave inversion 2 to 5 days. T wave recovery weeks to months. And persistent ST elevation, if it present beyond a few weeks, then it indicates there is LV aneurysm. Look at this example. Anterior ST elevation, V2, V3, V4, V5, V6, a little bit. These are the T wave are still very much upright. There is ST elevation, also hyperacute T wave. 1 AVL, there is slight ST elevation. Now, this is a classical example of hyperacute T wave. Please remember this picture. Look at the T wave in V2, V3, V4. This is called De Winter's T wave. These big, very peaked, tall T waves, when the patient have chest pain, this suggests very acute MI. De Winter's T wave, remember that. Now, that's the classical picture we give in the exams. Do you not? ST elevation in V1 to V5, tombstone pattern. The patient have severe occlusion and severe damage. A tombstone actually suggests that you are a very much good candidate for going to Azimpur graveyard. Again, there is a tombstone pattern along with there's reciprocal ST depression in 3 and AVF. Why does reciprocal ST depression occur? At the right angle of the area where MI is occurring. In case of inferior MI, you can get ST depression in 1 and AVL. In case of anterior MI, you can get ST depression in 3 and AVF, like this. There may be some atypical electrocardiographic presentation, like Vanderbrandt's block. And we have some criteria to decide about that. And what is that criteria? Carvosser criteria. Now we are using the modified Smith-Carvosser criteria. Look at that. Concordant ST segment elevation more than 1 millimeter in at least 1 lead. Where the QS complex is positive, in LBB, you are supposed to get an opposite ST segment T wave. But if you get instead a ST elevation on those leads, the lateral leads, then it's MI. The score is 5. But other way around, if there is concordant ST depression more than 1 millimeter in V1 to V3, you are supposed to get ST elevation in association with LBBB in anterior leads, V1 to V3. Instead, you are getting ST depression. That's MI. Discordant ST elevation more than 5 millimeter in leads with negative QRS. If the QRS is too much elevated, then also that's not normal, but the scoring point is low. Modified Smith-Carvosser criteria suggest any single lead with at least 1 millimeter of discordant ST elevation, that is more than 25% of the preceding S wave, suggests there is acute MI. However, remember that LPP alone is not an indication to activate cath lab. That's very true for European and American countries. Make ischemic call if patient is unstable with LPPP. Otherwise, assess the patient properly. Look at this one. Look at lead 1, wide QRS complex, FEL, wide QRS complex. Look at V5, V6, wide QRS complex, that's LBBP. But I am supposed to get ST segment depression and T wave inversion. I'm here getting that the T is upright. There should not be. There is a primary event in there. And that suggests this could be a case of acute MI. Isolated posterior myocardial infarction, we get tall R in anterior leads. Ischemia due to left main coronary artery occlusion or multivessel disease. There will be ST depression in multiple leads. When it is 8 or more surface leads, and there is also ST segment elevation in AVR and or V1, that strongly suggests it's left main or left main equivalent. Let's have some example. In this ECG, there is ST segment elevation in 2-3 AVF. So that's the acute ST elevated inferior MI. And we are getting ST depression in 1 AVL. So that could be reciprocal change. But what about the change in V1, V2? There is ST segment depression, T inversion. And the R wave in V1, it seems it's not expected that the R in V1 should be equal to the S in V1. The ratio has become almost 1. So there is RV infarction suggesting. Now, whenever you get inferior MI, also look at the lateral leads. 5, 6. Yep, we got it. We are having here ST elevation in V5, V6 as well. So this is an inferolateral MI with posterior infarction because of the tall R in V1. And that could be, if we do a right-sided ECG, this is a right-sided ECG, and that ST elevation actually suggests we are having a RADV infarction as well. Inferoposterolateral, look at this one. Q wave in 2-3 AVF, slight ST elevation. V6, a Q wave, slight ST elevation. Tall R with upright T in V2, particularly, also on V1. That is inferior, posterior, and lateral. All these are involved. Pure posterior MI. Many of these patients have chest pain. The physician is saying ECG appears to be normal, but top eye is raised. But if you look at it carefully, tall R in V2 with an upright T, actually, there's an isolated posterior MI. Uncommon, but not rare. Now, look at this one. There's ST depression in so many leads, and that's horizontal ST depression. But there is ST elevation in AVR. That strongly suggests left main coronary artery occlusion. Now this one, right side ECG done as indicated, we are getting ST elevation in V3R, V4R, V4R, V5R, also V3R. That suggests RV infarction. Why do we put the leads in right-sided ECG? Look at that one. Just opposite what we do normally. What about the posterior leads? If take out the V1, V2, V3 and put it in V7, V8, V9 position at the same level of V6 in posterior axillary line, mid-scapular line, paraspinal line at the same plane, and that's the posterior leads. There could be mimics of ST elevation in FER. particularly if the patient has tachycardia. This is not a typical atrial flutter. You are not seeing the typical sawtooth appearance, but look at V2. You are getting very sharp looking T waves. T waves are not supposed to be like that. Now, if you look carefully, we'll find out actually these are P waves occurring very rapidly. This atrial flutter. And the ST elevation, when it occurs in association with a supraventricular tachycardia, like this one or the previous one, we should not count that as an acute MI or left main occlusion or anything like that. We should convert it to sinus rhythm, look at the ECG again, then decide what type of MI it is. And what's the aim of STEMI management? First of all, we want to prevent death. We want to limit the extent of myocardial damage. We want to give comfort to the patient. How do we do that? We have to open up the artery. How do we do that? The best way, if you do it mechanically. Thrombus is a mechanical barrier. If you open it up mechanically, the artery, you are doing a lot of good to the patient. So primary PCI is the first choice. We can do it pharmacologically if we can thrombolize, if we use the clot busters. What about an admixture? We do not have primary PCI facility available in most of our country. We can go for pharmacoinvasive. Use the thrombolysis and rapidly send the patient in a center where PCI can be done and do it. And there's, we'll find out almost equivalent in some cases, if done very early on, almost equivalent to primary PCI. But are we doing it properly? This is an example of traffic jam in a European country. Just multiply it by 10. You will get the picture in Dhaka and everywhere in this country. So they are saying that European assessors assessment, more than 1/3 of STEMI patients referred to a PCI center for primary PCI failed to achieve a time delay of less than 120 minutes. That's the goal. We want to open up the artery within 2 hours of first medical contact. Most of the time, they are capable, but at least 1/3, they cannot do it even in a very developed country. But we know that time is muscle. And so, yes, in 2017, they suggest if you can do it, if the patient is calling an emergency service, you have to do this very rapidly, within 10 minutes, diagnose it. And then you go for primary PCI if you can do it within 90 minutes. Or you can do the fibrinolysis. You should do it very rapidly, giving a lytic bolus, and then send it for PCI. If systems are required that ensure rapid fibrinolysis before transfer to PCI center, how can we do that? We have materials, we have means for doing that, but we do not have the financial means of ensuring that end. We'll talk about that later on. So let's say the patient has arrived in the emergency department with chest pain. There should be quick trials with every patient with chest pain. The clock starts with the first medical contact. That may be a paramedic, that may be a doctor. See the blood pressure, heart rate, oxygen saturation. Give oxygen if it's less than 90%. ECG. Do it rapidly. If you are capable of interpreting it, interpret it. If you cannot do it, take a picture. Send it through WhatsApp or Viber or whatever it is to a person who can do it. Ask his opinion. What is the matter? What is happening? And if the patient has chest pain is significant, attach the patient to a monitor with defibrillator pad. If possible, establish an IV line in the ambulance and send for these tests. If possible, Not possible in our country most of the time. Take a brief history, do a brief physical exam, and think if this could be anything other than STEMI. We should relieve the hypoxemia. Oxygen is indicated in patients with hypoxemia. Otherwise, oxygen is not needed. If it's less than 90%, then give oxygen. Because if you give oxygen, the systemic vascular resistance will be increased. That will put an added burden to the heart. Again, if there is reperfusion, this excess oxygen is going to create free radicals, reactive oxygen free radicals that will do more damage. And that's why if the patient do not have hypoxemia, do not give oxygen. And to relieve the pain, the best thing is IV opioids. We can use a mild tranquilizer, benzodiazepine, but IV opioid is the best choice. We should give aspirin. In our country, we do not have chewable aspirin. All we have is 75 milligram enteric-coated aspirin. So if we see a patient, we have to crush the tablets and give it. Or tell the patient, crush it by your own teeth and then swallow it. We can use the loading dose of P2Y12 inhibitors, clopidogrel or ticagrelor, or whatever it is. We should use the opiate analgesic, particularly morphine. But be careful with the elderly patient because there could be respiratory arrest. And if you are using an opiate analgesic, you should be giving an antiemetic, either prochlorperazine or nonceptrol or metoclopramide. Sublingual nitroglycerin tablet or spray can be given for chest pain, particularly if the blood pressure is elevated. But if the patient is hypotensive, please don't use it. If the patient have inferior MI, be careful about using it. If the patient have associated RP infarction, you can further aggravate the situation by reducing the blood pressure. If the blood pressure is too much elevated, we should start a nitroglycerin drip. If you cannot do that, if you are on a way, use sublingual nitrate for reducing the blood pressure because sublingual nitrate acts within seconds, but the action lasts not for much more, few minutes only. So you have to repeatedly use the sublingual nitrate to control the blood pressure if you do not have anything else. If the patient is hemodynamically stable, oral beta blocker can be given. IV beta blocker could be given only if there is raised blood pressure and tachycardia. We must not use it in hypotension or bradycardia. I prefer, in our country, oral beta blocker is safer. High dose starting, we should be using it routinely as the first medical contact person. Atorvastatin 80 mg or rosuvastatin 40 mg orally. ACE inhibitor or ACE blocker should not be given immediately, but should be started within 24 hours, particularly if the patient is hemodynamically stable. If it is he or she is not stable, do not start it very early on. Epidemiologic therapy, pharmacological opening up the occluded artery. We are going to use a very powerful drug. So we should be knowing what are the absolute contraindications to that. Any patient with previous history of intracranial hemorrhage or stroke of unknown origin at any time should never get a fibrinolytic therapy. If you have a ischemic stroke in the last 6 months, don't use it. If you have suspected ICSOL, intracranial neoplasm or malformation, don't use it. If you have major surgery or trauma to the head in the preceding month, don't use it. If you have bleeding or if you are now bleeding disorder patient, you do not use the fibrinolytic therapy. But if you are undergoing menstruation, you can use it unless the patient have heavy, very heavy mens. Another thing is aortic resection. This is very, very important because you're going to kill by using fibrinolytic therapy if you do not diagnose aortic dissection properly. So the proper history about the nature of pain, whether it is a retrosternal tearing type of pain leading to the back, and there is a difference of blood pressure and pulse, volume or pulse between right and left hand, you should suspect aortic dissection and should not be giving fibrinolytic therapy. And if you do a liver biopsy or lumbar puncture within the last 24 hours, we should not be using fibrinolytic therapy. There are some relative contraindications. TIA in past 6 months, oral anticoagulation therapy, unless there is evidence that the INR is too high, pregnancy or within 1 week of postpartum, that's actually relative contraindication. Refractory hypertension. If the patient have a high blood pressure, we should reduce the blood pressure by using IV nitrate, then start using fibrinolytic therapy. Advanced liver disease, infective endocarditis, and prolonged traumatic resuscitation. What do you mean by that? More than 15 minutes. Somebody says more than 20 minutes. But if it's very traumatic, you should be cautious about using fibrinolytic therapy because you may lead a hemorrhagic pericardial effusion and tamponade. The patient may survive the MI but may die of the tamponade. And choice of thrombolytics, we are using streptokinase. It's the age-old drug, but it cannot be given as a bolus. It lacks fibrin specificity and is very antigenic. Alteplase, reteplase, not available in this country. I'm not going to talk about it. But tenecteplase, it has the highest fibrin specificity and resistance to plasminogen activity inhibitor, if you consider it in comparison to RTPA. And it's a single bolus with equivalent efficacy and improved safety profile to antiplase. It's a very good drug, but very costly. If we can arrange in this country that our patients are going to get tenecteplase free of cost or at a very reduced price, that will be huge change in the scenario where MI is not going to kill you or is not going to make you an invalid person, because you will have a very open artery. That means you will have a better heart, you can work, you will not be invalid anymore. But the cost is so much. And then we know that there is weight-adapted doses of tenecteplase. One thing I am drawing attention to everybody. TNK is incompatible with dextrose solution. You must not use any line that contains glucose. It can be used with only distilled water available with the packaging of the tenecteplase or with 0.9% sodium chloride, normal saline. Do not use DNS, do not use dextrose, do not use anything that contains glucose. It has a half-life only 18 to 20 minutes. So we should have to use an anticoagulant immediately. IP enoxaparin, widely available in this country, should be used within 15 minutes of administration of tenecteplase and then continued as a subcutaneous dose twice daily for at least 48 hours. What anticoagulation therapy we can give? Look at this. Anticoagulation is nowadays recommended in patients treated with lytics until we do the revascularization proper, or for the duration of hospital stay of up to 8 days, we can give it even after using streptokinase if we need it. How? Enoxaparin IV followed by subcutaneous. You have to use IV enoxaparin, half the dose IV stat, then again subcutaneous dose stat and twice daily. You can use unfractionated heparin. In case of streptokinase, one study suggests fondaparinux is better, and we have that now. Nowadays we can use the IV bolus and transfer. Now look at this. This is the dictum nowadays, class 1 suggestion level A evidence. transferred to a PCI-capable center following fibrinolysis in all patients immediately after fibrinolysis. If you say, I have used the streptokinase and the patient is unstable, I'm not going to send it, you are doing wrong. The evidence is there. The suggestion, the guideline is there. Class 1 indication. You should transfer the patient immediately unless the patient is very much unstable. And within 2 to 24 hours, we can do the NGO and we can open up the artery, the residual stenosis, whatever it is available is there. That's pharmacoinvasive. And that should be the treatment modality in our country. Enoxaparin, 30 milligram IV bolus, followed by 15 minutes later, 1 milligram per kg subcutaneous dose every 12 hours. Remember that. But if you are more than 75 years, no IV bolus, just start with 0.75 milligram per kg subcutaneous dose. If you have lower EGFR, the dose should be the EGFR less than 30 ml. In CKD stage 4 or 5, then you should be using enoxaparin once daily dose. If you are using tenecteplase, which is very effective, you should be careful. The blood pressure should be lowered down. Less than, if it is more than 160, you should rapidly lower it by IVGTN or anything. If you have recent gastrointestinal or genitourinary bleeding, you should be careful about using it. If you have within 2 days intramuscular injection, if you use tenecteplase, you are likely to have a huge hematoma in that place. If the patient is advanced age, over 75 years, you should be using half the dose. If you have cerebrovascular disease, you should be careful about using it. Consider whether to use it or not. It's a potent drug, very good result, but can be devastating if you do not use it with precaution. What does clinical trials of tenecteplase suggest? That's a treatment, tenecteplase versus streptokinase. Now, look at the blood flow. This TB flow actually means TB0, no flow. TB1, only slight flow going beyond the obstruction, slightly visualizing the vessel. TB2, the vessel is visualized, but the flow is a little bit sluggish. TB3 flow, there may be obstruction is still there, but the flow is going and it visualizes all the branches. That's TB3 flow. That's what we aim for. We want to achieve TB3 flow either by primary PCI or pharmacokinetic PCI or by thrombolysis. In case of tenecteplase, we can get it 74% time, but with the streptokinase, only 30% time. TB2 flow, 18% and 20%. So if you use tenecteplase, more or less satisfactory flow, you can achieve around 90% time or more with use of tenecteplase, but only about 50% time with use of streptokinase. That's a huge difference in there. So it's much better than streptokinase. Look at this. We have already talked about it. The success rate is 93% with tenecteplase, around 45% or less with streptokinase. This is the study showing that the overall rate for achieving clinically successful thrombolysis by tenecteplase was 93.34%. That's the study suggests. What is it? If you are thinking about in our country, we do not have primary PCI facility most of the time. Less than 1% of our patients are going into there. And even in a center where primary PCI is available, only 6%, one study suggests, only 6% patients are availing that facility because of financial implication. So this study stream strategic reperfusion early after myocardial infarction. They take a strategy of early fibrinolysis followed by coronary angiography within 6 to 24 hours or rescue PCI if needed. That was compared with standard primary PCI. Very interesting. Percent of patients who have composite endpoint of death, congestive heart failure, cardiogenic shock or myocardial infarction. If it is less than 55 minutes, primary PCI, the pharmacoinvasive PCI, more patients are going to have that endpoint. That means primary PCI better. But when the time frame is increasing, you cannot do the primary PCI very early on. In that case, pharmacoinvasive PCI appears to be better because you are achieving somewhat a better blood flow at more early on. The facility for doing the primary PCI, the logistic, the manpower, the expertise, everything is limited. So that is the problem. In that case, go for fibrinolysis. Then send the patient within 24 hours, do the angio, and open up the artery as needed. And that's the relative risk. With primary PCI 14.3%, TNK 12.4%. So its team suggests as PCI-related delay increased, pharmacoinvasive strategy outcomes become superior to primary PCI. In such circumstances, a pharmacoinvasive strategy may provide an alternative to reperfusion option. So we should prevent a system delay and save the patient's life by using pharmacoinvasive therapy if you cannot resort to primary PCI. Now, whenever we are seeing the TB patient, we should use a risk score to predict the 30-day mortality. There's the TB risk score available in the net. Anybody can use it. And so in case of patient after discharge, when are we going to assess the patient by echo again? If there is LV dysfunction, we should do it after 6 to 12 weeks. Because within that time, the stunned or hypernating myocardium are getting some time to recover. And after complete revascularization of pulmonary therapy, we should use it. We should see it. What about the drugs? Class 1 indication for beta blocker within first 24 hours. If they do not have heart failure or low output or a chance of cardiogenic shock or other contraindication like complete heart block, a second or third degree heart block, or say active asthma. They should be continued during and after hospitalization for all patients with the STEMI who do not have any contraindication to their use. IV beta blocker, I'm not going to talk about that because it can lead to cardiogenic shock if we do not use it properly. What about lipid therapy? High intensity statin for all patients if no contraindication. Atorvastatin 80, rosuvastatin 40. And we want to obtain a fasting lipid profile within 24 hours. ACE inhibitor. An ACE inhibitor should be administered within the first 24 hours to all patients with anterior MI or any MI patient, inferior, posterior, lateral, or whatever it is, if they have heart failure or if they have LV dysfunction. ARB can be given instead if the patient have any problem with the ACE inhibitor. And class 2 indication, they are reasonable for all patients, even if the patient have reasonably good LV function, let's say 50%. But still then is class 2 indication. We should be using it. MRA, aldosterone antagonist, when the patient have low ejection fraction or symptomatic heart failure or diabetes mellitus. But the patient should be receiving an ACE inhibitor or beta blocker already. For cardiac arrhythmia, IV emitter is better. We can use IV beta blocker. And complete revascularization is recommended to treat myocardial ischemia that may be present in patients with recurrent VT. We should look at the electrolyte and correct it. If the patient has bradycardia, we can use epinephrine, vasopressin, or atropine to raise the heart rate. We can use the temporary pacing, And we can go for urgent angiogram because revascularization may restore the heart rate to normal. And most of the time it do, class 1 indication. If there is LV dysfunction, ACE inhibitor or ARB, beta blocker, MRA, loop diuretic as needed. Nitrate. Nitrates are recommended in patients with symptomatic heart failure, but the patient should have a systolic pressure more than 90. Oxygen is indicated if the patient has pulmonary edema or pulmonary pulse oximeter, we see that the saturation of oxygen is less than 90%. We want to maintain a saturation more than 95%. Intubation if needed. Non-positive, invasive positive pressure ventilation is can be considered, but we should remember that it may induce hypotension. PCI, cardiogenic shock. For cardiogenic shock, the choice of treatment is actually PCI. We should do the invasive blood pressure monitoring. We can do the echo to see that if there is a mechanical complication, but respiratory support may be needed, and PCI is the choice. If we cannot do that, we should use fibrinolytics. But complete revascularization is the ideal thing. IAPP, intra-aortic balloon pump, help may be needed. Nowadays, Impella, a type of ventricular assist device, is very, very helpful. Unfortunately, very expensive, not yet available in this country. Atrial fibrillation. We can use the intravenous beta blocker or intravenous emitter. Cardioversion as needed. Particularly in case of AF, if the patient has ongoing ischemia and hemodynamically unstable, we should do it. IV emitter for recurrent VT. In case of primary VT that occurs with MI within hours, most of the time they do not recur if we can achieve successful thrombolysis or successful primary PCI. ICD is a long-term thing. Cardiac arrest patient. A primary PCI strategy is recommended in patients with resuscitated cardiac arrest and ECD showing STB. DFib. All medical personnel, paramedical, medical personnel should have training in using it, and it should be available everywhere. Urgent angiography should be considered in patients with resuscitated cardiac arrest without diagnostic ST elevation. But if we think there is ongoing myocardial ischemia. This is the book that has been recently published, Handbook of Management of Acute ST elevation, Myocardial Infarction. I'm one of the editors. Healthcare is publishing it with the help of BD physicians. It's available free of cost. Those who are interested, please, only 86 pages, around 80 pages of actual valuable information. You can use that. You can get it if you contact healthcare. And many of the information and all the ECGs I have used has come from this book. Non-STEMI is another part, a little bit different. They have chest discomfort, but no persistent ST elevation. There could be transient ST elevation or persistent or transient ST depression, TUF infarction, flat TUF or pseudonormalization, or that's the catch point. ECG may be normal, even with a typical chest pain and raised tropi. Now, tropi, the levels of tropi should be interpreted as quantitative markers of cardiomyocyte damage. If you have higher level, the likelihood of MI is much more. More than 5-fold the limit is positive predictive value for acute type 1 MI is more than 90%. If it is 3-fold, 50 to 60% positive predictive value for MI. But it could be due to other causes, including myocarditis. That's what we are seeing in case of COVID. Rising and falling cardiac troponin level differentiate MI from chronic myocardial site damage. acute condition, there will be acute rise, acute fall. In chronic condition, there will be certain level of rise, not that much, and it may persist. And how do we treat non-STMI? If it's suspected, we have to rule in, rule out. By how? ECG, history, troponin, if needed, echocardiography. If the patient, I do think there is not a significant cardiac patient, we can discharge him and we can go for stress testing or cardiac CT angiogram. We can send the patient in low-risk patient for what? To do the angio or CT angiogram or stress testing later on. If the patient has high-risk features, we should send the patient to CCU or to cath lab. They have to have treatment very early on. Imaging in this patient are very helpful. We should do the echocardiographic class 1 indication. And in patients with no recurrence of chest pain, ECG is normal, troponin is normal, but we are suspecting there could be some underlying cardiac disease. We should do a non-invasive stress test, an ETT or a stress echo. We can do the cardiac CT angiogram as alternative to exclude in low to intermediate likelihood cardiac coronary artery disease patient, where the troponin is inconclusive. This suggests the very high risk and high risk group A, immediate invasive if the patient have very high risk. Look at this one. Hemodynamical instability, cardiogenic shock, recurrent chest pain, life-threatening arrhythmia, mechanical complication, acute heart failure, ST segment depression, as well as ST elevation in FVR and V1. Everywhere ST depression, that means you are suspecting like left main equivalent or left main disease. These are very high risk. You should take the patient immediately for angiogram and subsequent treatment. If the patient have troponin raised, new or presumably new ST segment change, or there has been cardiac arrest, but there is no ST segment elevation, or Graves' disease score is more than 150, these are high risk. They should undergo angiogram as early as possible, but not immediately. Low risk patient, we can use a conservative approach. What anti-ischemic, sublingual or IV nitrate? We can use the beta blocker early on. That's very important. And we should continue it. IV nitrate, particularly in patients with uncontrolled hypertension or signs of heart failure. And if we suspect the patient may have prince-metal angina, we should be using, instead of beta blocker, calcium channel blockers. Aspirin for all. PT-Y12 receptor can be given with aspirin, maintained about 12 months, unless there are contraindications or excessive bleeding risk. We can use the prasugrel or ticagrelor, but first two, aspirin and clopidogrel, are the choice. What about antithrombotic treatment? If you are going to do the PCI, prasugrel is the most powerful oral antiplatelet. Second most powerful is ticagrelor. Third is clopidogrel, and the aspirin comes as sorry fourth. GP2B antagonist should not be used unless there is a complication during PCI. And look at this. Pre-treatment with clopidogrel type medicine should maybe consider in patients non-STMI who are not planned to undergo early invasive strategy and do not have a high bleeding risk. But if you are thinking we are going to take the patient to the cath lab, we better use a aspirin and enoxaparin and then take patient to the cath lab. Parenteral anticoagulation for all patients in addition to antiplatelet diagnosis. What does that mean? Either unfractionated heparin or enoxaparin or fondaparinux. We can sometimes maybe use by bilirubin if the patient have history of allergy to heparin or have history of heparin-induced thrombocytopenia. But if you're using unfractionated heparin, we should not be crossing over to the low molecular heparin and vice versa. It's not recommended. That's 3. What about heart failure and cardiogenic shock? Emergency angio, emergency PCI, emergency CABG. Go to the highest length available to you, because cardiogenic shock is like a death bell. 70% or more mortality. In my country, I don't know, maybe could be more than 80% or 90%. What about heart failure, cardiac shock? If they have mechanical complication, IABP should be used. Other circulatory device, unfortunately not available in the country, particularly as I was talking about Impella, very successfully used in these patients. Ladies and gentlemen, acute MI is a medical emergency. Good return is very likely if your investment in terms of knowledge and skill are used in proper time. Time is cardiac muscle. So action need to be swift and specific. The drugs we are using in treatment of acute MI are very potent, so their use should be judicious. Cardiac patients become very much functional if well treated. They become a very well-functioning, contributing citizen of this country, economically viable, economically contributing. So we should be trying to treat them early on and very well. I hope today's lecture may give you some information to make a better physician. Thank you, sir. Thank you, everybody.
Thank you so much, sir, for this amazing presentation. Now it's time for the question and answer session. I can see many questions in the comment section, but we will be able to answer few of them. I request Dr. Pankaj, sir, to start the question and answer section. Dr. Pankaj, sir.
First of all, I congratulate Professor Wadud, sir, for his nice and elaborate elaboration today. I hope every viewers and listeners have enjoyed very much. Now I am going to the question and answer session. We can see the chat box is full of questions, but due to time constraint, I will not be able to pick all those. Before picking a question from the chat box, earlier today, while I was sharing the program brochure to a WhatsApp group, one of my colleagues asked me why the name of the topic is acute management of MI. Why not management of acute MI? Can you please say something on it, sir?
Time is muscle. Acute management, you have to act very swiftly, very quickly. To put emphasis on that aspect, the acute comes before anything.
Thank you, sir, for the nice answer. Now I'm going to pick few questions from the chat box. A very practical question from our country perspective, asked by Faisal Ahmed. A patient has reached the hospital of a peripheral hospital within 12 hours, but there is no facility to do primary PCI within 120 minutes. And it is not possible to send to Dhaka within that time period. So what should we do? Should we do pharmacological thrombolysis, sir?
That's why I'm suggesting. আমরা কিন্তু এটাই বারবার করে আমরা বলছি যে আমি পেশেন্ট পাঠাতে গিয়ে আমার মনে আছে উত্তরা থেকে পেশেন্ট রওনা হয়েছে, আমার পেশেন্ট এমআই হচ্ছে, আমি লেবিতে বসে রোগী আসতে আসতে পথের মধ্যে মারা গেল জামে পড়ে। আমি 1.5 ঘন্টা 2 ঘন্টা ধরে বসেছিলাম, কারণ উনি আমার বহু পুরাতন পেশেন্ট, আমাকে খুব আদর করে। তো সেই দুঃখ আমি ভুলতে পারি না। এই টেনেক্টেপ্লেজের মতো ওষুধ যদি থাকতো, সহজে অ্যাভেলেবল হতো, তাহলে কি করা হতো? বলতাম এক্ষুনি ওখানে দিয়ে দাও, জাস্ট ইঞ্জেকশনটা দাও, তারপর আইভি হেপারিনটা দাও, দিয়ে তারপর তুমি রওনা করো। আমি কিন্তু আসল ট্রিটমেন্ট অলরেডি করে ফেলছি। এবং এইখানেও আমি তাই সাজেস্ট করি। আমরা কিন্তু তাই দেখছি। আমি তো আজকে তো ওগুলা তো দেখাইনি, নমুনাগুলো দেখালে বোঝা যেত যে কি অ্যামেজিং রেজাল্ট অ্যাভেলেবল হয় যদি সময় মতো টেনেক্টেপ্লেসটা দিয়ে আমরা যদি পাঠাতে পারি। স্ট্রেপ্টোকাইনেসটা খুব বড় প্রবলেম হলো, অনেক সময় লাগে, সিরিজ পাম্প লাগে, অ্যান্টিজেনিসিটি বেশি, প্রবলেমগুলো বেশি এবং কমপ্লিকেশন বেশি, আউটকাম হলো অনেক কম। তার ফলে হয় কি, রুগীর ওষুধ দিলেন, একটা পটেন ওষুধ দিলেন, দেখা গেল প্রবলেম হলো রুগীর লোকজন উল্টা আপনার উপরে খেপবে, হ্যাঁ কেন দিলা, একটা কি ওষুধ দিল দিয়ে মেরে ফেললো। You are getting better result with that available. The point is, can we make it available throughout this country from government source? How much money it will cost? 20 crore? 20 কোটি টাকা ম্যাক্সিমাম লাগবে সারা দেশের সব মানুষের, মানে যে এমআই পেশেন্টের জন্য দিতে গেলে। সে তো কিছুই না, শুধু অ্যাভেলেবল করতে হবে। এবং সেটা যদি হয় এই দেশের, আমি তো বলবো যে আমাদের একটা রেভলিউশন হবে acute ম্যানেজমেন্টের ক্ষেত্রে।
Yes, thank you, sir. We hope our policymakers will think about it. Now another question, it's about statistics asked by Moshur Rahman. Is there any data in our country regarding prevalence of RV infarct in inferior MI cases, sir?
RV infarct as a whole, যে আমাদের যে থিসিসগুলো হয়েছে সবখানে বলে অ্যারাউন্ড 1/3 পেশেন্ট, বিভিন্ন যে থিসিসগুলো আসছে এবং ইন্টারন্যাশনাল স্টাডিও 1/3 পেশেন্টদের RV ইনফ্যাক্ট থাকে। এর মধ্যে আবার 10% পেশেন্টের এমন কিছু প্রবলেম হয় না, 20% পেশেন্টের কিন্তু খারাপ হয়ে যায়। RV ইনফ্যাক্ট কিন্তু ওয়ান অফ দ্য সিরিয়াস প্রবলেম, কারণ আপনার ট্রিটমেন্ট স্ট্র্যাটেজিতে একটু আলাদা। আমি এখানে সাবলিকাল নাইট্রেট দিব না, আমি তাকে মরফিন দিব না, আমি তাকে এসি ইনহিবিটর দিব না, এটা কিন্তু খুব ইম্পর্টেন্ট। তো এটা যদি না বুঝে আমাদের যে কমন যেটা ট্রিটমেন্ট, যে এমআই হয়েছে এই নাইট্রেট দিয়ে দাও, তাহলে কিন্তু খারাপ হয়ে যাবে।
Thank you, sir. Already we are running out of time. I'm asking permission to Chairman, sir, if we can take a couple of more questions, sir, because there are some important questions in the chat box.
আমার মনে হয় আরো 2টা কোশ্চেন তুমি নিতে পারো।
Thank you, sir. One question asked by Mijanur Rahman. Sir, please tell the update recommendations for the drugs used for thromboprophylaxis in PCI and CABG with duration of each drug. Sir, please.
আমি কিন্তু এই ফোরামে এটা বলবো না, কারণ ওটা কিন্তু অল্প কথায় বলার জিনিস না, এবং আজকের ম্যানেজমেন্ট কিন্তু অ্যাকিউট এসটি সেকেন্ডারি এলিভেশন এমআই ম্যানেজমেন্ট, কাজে হাফ ডান কথাবার্তা বলা উচিত না। তবে খুব সিম্পল কথা, ডিএপিটি আমি ইউজ করব 1 বছর ইউজ করব। যদি হাই রিস্ক ফিচার থাকে আমি প্রলং ডিএপিটি ইউজ করতে পারি। আমার ফার্স্ট চয়েস ড্রাগ অ্যাসপিরিনের সাথে টিকাগ্রেলর অথবা প্রাসুগ্রেল। যদি ব্লিডিং রিস্ক থাকে আমি প্রাসুগ্রেলটা আমি কিন্তু অ্যাভয়েড করব, সেক্ষেত্রে কিন্তু ক্লোপিডোগ্রেলে ফেরত যাব। যদি সিকেডি থাকে, বয়স্ক পেশেন্ট হয়, টিআই এর হিস্ট্রি থাকে, তখন কিন্তু আমি পটেন্ট ড্রাগগুলো পরিবর্তে একটুখানি লেস পটেন্ট কম্বিনেশনটা ইউজ করব। আমি লং টার্মে নিরাপদে ভালো চাই, সেটা মনে রাখতে হবে। আর যেটা খুব প্রবলেমের ব্যাপার, রুগীর পিসিআই করা হয়েছে, রুগীর হাই রিস্ক পেশেন্ট ছিল না, তার লম্বা স্টেন্ট দেওয়া হয় নাই, বছরের পর বছর ডিএপিটি পাচ্ছে এবং পরে ইন্ট্রাক্রেনিয়াল হ্যামোরেজ নিয়ে নিউরোসার্জনদের চেম্বারে গিয়ে হাজির হচ্ছে বা হসপিটালে হাজির হচ্ছে। এটা খুব একটা বিরাট একটা খারাপ ব্যাপার হয়ে যাচ্ছে। সবাই এই ব্যাপারটা নজর দেওয়া উচিত।
Thank you, sir. I think Abdur will look into this matter. And the last question from Al Russell Mustafa. Some MI patient develops bleeding after STK treatment. How can we manage STK-induced bleeding?
Very problematic, because you have used a potent drug and you are using also antiplatelets. So conservative treatment and giving blood transfusion if needed. Plus, using tranexamic acid is dangerous. We should not be using, because it is very unpredictable outcome.
So hope your practical answer could satisfy the one who asked the question. Now I am going to the panel experts for their remarks. First, I'd like to request Professor Brigadier General Abdur Razzak sir to go on with his remarks. Sir, please.
আনমিউট করতে হবে রাজাক ভাই।
Now you can hear me?
Yeah.
Okay. Respected chairperson, great teacher, my mentor, and great academician, Professor H.M. Nazmul Ahasan, Governor ACP, Bangladesh chapter, and former President Bangladesh Society of Medicine. Today's speaker, renowned cardiologist and great orator, my younger brother, Professor Abdul Wadud Chowdhury, Professor and Head Department of Cardiology, Dhaka Medical College. And my co-panelist, Professor Mahabubul Majumder, Professor and Head Department of Medicine, Central Medical College Hospital, Kumilla. And my dear moderator of today's health talk on management of acute myocardial infarction, Dr. Pankaj Kanti Datta, Assistant Professor, Department of Medicine, Dhaka Medical College. Last but not the least, the orator of the learned audience, those who have joined to this virtual platform. Assalamu alaikum and very good evening. I am Brigadier General Abdur Razzak, Chief Physician, CMS Dhaka. Actually, I'm very much grateful to organizer for selecting me as the panelist. And after the vivid description and narration by the orator, there is hardly anything left for us to mention about the management. However, as a panelist, it is customary to say a few words. Actually, we have learned a lot new things from the speaker. Amongst that, regarding the management, as you know, the treatment of the acute myocardial infarction is time critical, and it is said that minutes means muscle. The main idea is to revascularize the acute MI patient, especially in the STMI elevation MI, through primary PCI or through fibrinolytic means. As we have heard, the primary PCI is always a better option, but due to logistic problem and cost economic problem in third world country like us, we cannot afford always. Because the patient presence late, there is traffic jam, and moreover the issue of cost, and there is no facilities everywhere in the country. That's why we cannot go for the primary PCI in the first instance. And regarding the thrombolytic therapy, the time-old drug Streptokinase has been used in our country, but to some centers, including CMS Dhaka, recently has started to use this LP place instead of Streptokinase. And it is much more efficacious, and there are some advantages also, as the speaker said. It is not antigenic, does not produce hypotension, and it can be used, and it does not produce the antibody, that's why it can be used repeatedly in future acute MI also. It is also FDA approved for the ischemic stroke patient. And details of the management has been discussed, though it is not very pertinent to the prevention aspect, but we can take the privilege to say a few words. Before the preventive aspect, we have to know the risk factors also. As you know, the hypertension, diabetes, smoking, both active and passive, dyslipidemia, older age group, male sex, family history and genetic factors, obesity and lack of physical exercise, and excess alcohol intake, combined oral contraceptive pill, emotional and physical stress, some environmental factors like pollution and extremes of temperature, then dietary factors like high intake of saturated fat and trans fat increase the chance of MI. And at times NSAIDs, then some infection are also responsible for the MI. And there are some rheumatological conditions like SLE, other vasculitis, then Kawasaki's disease, all this can produce MI. And high level of homocysteine level is also a factor. And other factor like coronary spasm and coronary artery dissection is also important. And we have seen that we know that the morning hours of the day, the incidence of MI is more. And now the preventive aspect, there are some primary prevention as well as secondary prevention. If we know the risk factors, there are many risk factors are modifiable. We can modify those, including stopping smoking, taking alcohol in the moderate dose, or better to avoid alcohol, then keeping healthy weight and avoiding excess alcohol, then control of the hypertension, blood pressure, diabetes, dyslipidemia, and substituting the unsaturated fat instead of saturated fat. And we must give emphasis on the public health awareness. So print and electronic media and through health workers, so that the people become aware and they report early to the health facilities for the treatment, and as well as the preventive aspect, we should give due emphasis. And of course, some drugs like aspirin, statin in a high-risk group. And after the MI, there are focus for the secondary prevention also, like stopping smoking, then gradual return to the exercise. Even 1 to 2 weeks after the acute MI, they can start gradual exercise. And of course, the eating of healthy diet, then drinking alcohol in recommended dose, or exercise and achieving healthy weight, and medication like aspirin, beta blocker, ACE inhibitors, nitrates, statin, spironolactone, all these have been nicely described by the speaker. So I don't like to linger my speech. I also give congratulations to speaker today and give thanks to the organizer once again for selecting me as a panel expert. With this, I want to conclude. Thank you very much.
Thank you, sir, especially your focus on preventive aspect of this medical emergency and the importance of taking care of the risk factors. Thank you again. Now I am requesting our another distinguished panel expert, a renowned clinician, Professor Mahabubul Islam Majumder sir, to go on with his remarks. Sir, please.
Thank you, Dr. Pankaj, for introducing me. First of all, I like to thank SCP for giving me the privilege to be the panelist in this program. Respected chairperson of this webinar, Professor H.M. Nazmul Ahasan, which is giving light in the path of the webinars and dispersing the knowledge of acute medicine to the persons of healthcare persons of our country. And my panelist, co-panelist, Brigadier General Professor Abdur Razzak, who has enlightened us with many aspects of acute ST-elevated MI and MI also, its management and risk factors. And above all, I think to give a speech or to give a presentation is a very, very hard thing, because the chairperson, panelists, they are not very much important, because they can conclude, they can give any comment from one side. But it is very difficult to give a thorough light throughout the whole topics. It is very, very difficult. And I think today, Dr. Professor Wadud has given a better, and it is not better, it is more than better, deliberation about the management, pathophysiology, and also the classification, as well as some of the recommendations from the latest recommendation about the management of elevated MI as well as non-ST elevated MI is very nice. I think a little thing has left for the management of MI. So I should say a little about this. In our country perspective, about 60 to 65% of the population has got STMI in the patient below the after the age of or at the age of 65 years, and after that at the age of 75 about 28 to 33% throughout the whole world or globally. But about the non-STMI in our country, I should say it will be less because we are not going for the biomarkers testing very oftenly. If there is any suspicion, we have to go for the biomarkers. But unluckily, in our peripheral parts, the biomarker usually come after hours. It will take up even 5 to 6 hours or more. In that case, it is very difficult to give the prompt treatment to the patient with MI. So it is one of the big question and big deprivation of the facility in our country. So the other thing is that we have to give the treatment to the MI patient. First of all, we have to relieve the ischemic pain. We have to give the hemodynamic state fast. We have to give the oxygenation properly. We have to give for the patient the proper facility for the reperfusion therapy, antithrombotic therapy, then the beta blockers, SC inhibitor, or air-based nitrate, and all other drugs are there. But I think first thing is that in our country, in most of the places in MI patients, morphine is not properly used or morphine is not used. It is the most important thing so far I have seen. They are using frequently miparavidin, that is parthirin, and along with parthirin, that is chlorpyrifos and others. And I should say in this platform that we should use morphine. Morphine is the drug of choice, that if there is no contraindication. So morphine should be given in the proper dose and patient will be relieved from the pain. It is very much important for the patient. Second thing is that the primary PCI is not available in all the countries. In Dhaka, Chittagong primary PCI can be done, but in other places, primary PCI is not available. In that case, we can go for the Thrombolytic Therapy. In that case, Streptokinase is the older drug, but with lesser efficacy. The latest drug, tenecteplase, is the better drug with better efficacy, but it's higher in price. The price is about more than 50,000. So our poor population cannot afford this type of this drug because it is a very high costly drug. But it is undoubtedly it is a very good drug. So the proposition from Dr. Wadud was that it can be given free of cost in the low cost in the hospitals so that patient can be beneficial with the MI patient can be beneficial with the treatment of tenecteplase, which is very effective therapy for us. Another thing I want to mention that in our country now we are only stuck to the COVID-19 patients. In this country, we can measure the oxygen saturation. If it is less than 90, in that case our target should be 95 and we will place it up to 95. About the colloids and crystalloids or ions, the American Heart Association also tells that the potassium should be kept around 4 and magnesium should be around 2 millimole per liter, and it is one of the important things we should take care about this. Another thing that is important, I should say, that type 2 MI is due to the non-perfusion. In that case, if the patient is very much anemic, if the patient is about 8 gram or low, in that case, patient should be given blood transfusion. Patient, if they have got blood transfusion, in that case, the perfusion will be better and patient will feel better and the myocardial infarction will be less harmful for the patient. And last of all, I thank again Dr. Professor Abdul Wadud Chowdhury. He is one of the close person, I should say, one of the close person, and he has given a nice deliberation which is better than anyone presentation. So thank Abdul Wadud again, and thank all the listeners for this presentation who are present in this webinar. Thank you very much.
Thank you, sir. I like to thank you especially for your very practical aspect of management with morphine due to pain in MI, and also our country perspective regarding the cost of the fibrinolytic drugs. Now, before going to the concluding remark from the chairperson, I like to thank Professor Abdul Wadud Chowdhury sir, because it was an excellent, amazing, awesome learning session for me. And I also like to thank ACP Bangladesh chapter, especially Governor sir and the team, for giving me the opportunity to be here with you. And I also like to thank Dr. Prince for coordinating these all broadcast things. Now, I like to humbly request Professor H.A.M. Nazmul Hasan sir, the chairperson of today's health talk, to come forward with his concluding remarks. Sir, please.
Thank you, Dr. Pankaj. Good evening, everybody. Assalamu alaikum. প্রথমেই আমি তো অবশ্যই আজকের স্পিকার প্রফেসর আব্দুল ওয়াদুদ চৌধুরী ওনাকে অবশ্যই ধন্যবাদ জানাবো ফর হিজ ওয়ান্ডারফুল প্রেজেন্টেশন। এই 1 ঘন্টার ভিতরে অ্যাকিউট ম্যানেজমেন্ট অফ মায়োকার্ডিয়াল ইনফার্কশন বলি বা ম্যানেজমেন্ট অফ অ্যাকিউট মায়োকার্ডিয়াল ইনফার্কশন বলি, এটা সব এত ডিটেলস বলে দেওয়া এটা ভেরি ডিফিকাল্ট। আমার মনে হয় যে আউটলাইনটা দেওয়া দরকার ছিল প্রফেসর আব্দুল ওয়াদুদ সাহেব ডেফিনেটলি সেটা দেওয়ার চেষ্টা করেছেন, এবং এর চেয়ে আর বেশি ভালো বলা সম্ভব না। আমরা সবাই এক বাক্যে জানি প্রফেসর আব্দুল ওয়াদুদ চৌধুরী এই মুহূর্তে বাংলাদেশের one of the senior most and most popular and academician and cardiologist of our country. I am proud to say about this. শুরুতে উনি বলছেন যে he is one of my student. এটা আসলে আমারই গর্ব লাগতেছে বলতে, যে মনে হয় 35 বছর আগে ঢাকা মেডিকেল কলেজে আমি যখন রেজিস্ট্রার ছিলাম, আমার মনে হয় 35 ইয়ার্সই হবে, সেই সময় আমার এখনো মনে পড়ে যে আব্দুল ওয়াদুদ চৌধুরী সবকে আমি ভুল করি নাই, যে তার বলার ধরন, তার অ্যাপ্রোচ, এগুলো দেখে তখনই মনে হয়েছে যে সে এক সময় একজন ভালো ডাক্তার, একজন ভালো ক্লিনিশিয়ান এবং দেশের একজন নামকরা প্রফেসর হবেন। আমি সত্যি সত্যি গর্বিত প্রফেসর আব্দুল ওয়াদুদ চৌধুরীর জন্য। আজকে 4টার সময় এসিপি বাংলাদেশ এবং আমেরিকান কলেজ অফ সার্জনস এবং পেডিয়াট্রিক ইউরোলজিস্ট এদের উদ্যোগে একটা রিজেনারেটিভ মেডিসিনের একটা কনফারেন্স ছিল। সেখানে প্রফেসর অ্যান্থনি আতালা ফ্রম নিউ অরলিয়ান্স একটা প্রেজেন্টেশন দিয়েছিল রিজেনারেটিভ মেডিসিন এর উপরে। তো মেডিকেল সায়েন্স তো সবসময় এত ডেভেলপ করতেছে প্রতিনিয়ত, এই জন্য এর সাথে কোপ করা তো কঠিন। তার যে সে 3 দশক থেকে হিউম্যান সেলস কিভাবে কালচার করা যায় সে এটা নিয়ে সে গবেষণা করছে। হি ইজ থট টু বি ফাদার অফ রিজেনারেটিভ মেডিসিন। কিন্তু আমরা এখন পর্যন্ত আমাদের কাছে এটা একটা ড্রিম বা হাইপোথেসিস মনে হয়, কিন্তু তারা এটা একটা প্র্যাকটিক্যাল একটা জিনিস যেটা ইউজ করতেছে ইউরেথ্রাল রাপচারে, অস্টিওআর্থ্রাইটিসে, আলজিমার্স ডিজিজে। তো আমরা কত পিছানো আছি, সায়েন্স কোথায়? তো আজকে আমি প্রফেসর আব্দুল ওয়াদুদ চৌধুরী সাহেবের যে প্রেজেন্টেশনতে আমি পার্সোনালি অনেক বেনিফিটেড হয়েছি এত কিছু জেনে। তো আমরা বলবো যে অভিজ্ঞতা আমাদের সিনিয়রিটির জন্য হয়তো আমরা অভিজ্ঞ, কিন্তু স্টুডেন্টরা, জুনিয়ররা যদি আরো বেশি না জানে তাহলে মেডিকেল সায়েন্স আগাবে না। এই জন্য স্টুডেন্ট জুনিয়রদের বেশি জানতে হবে। এই জন্য ওয়াদুদ চৌধুরী সাহেব যে যত ইনফরমেশন দিয়েছে, আমি আজকেও অনেক কিছু জানতে পারছি, কিন্তু দুই একটা জিনিস আমি একটু বলবো। দু একজন হয়তো বিভিন্ন বলার চেষ্টা করছেন যে ম্যানেজমেন্টটা আমরা এক সময় তো পেরিফেরি ডিস্ট্রিক্টেও কনসালটেন্ট হিসাবে কাজ করছি, রাজশাহী মেডিকেল কলেজ, খুলনা মেডিকেল কলেজ, আবার ঢাকা। আপনি ঢাকাতে ধানমন্ডিতে বসে থাকা উত্তরা থেকে একটা পেশেন্ট যদি পথে মারা যায়, আর পেরিফেরিতে একটা উপজেলার একটা এমআই চিকিৎসা তো আর ঢাকার মতো হবে না, তাহলে যে উপজেলায় আছে সে উপজেলার মতোই চিকিৎসা করতে হবে। আমি আর প্রফেসর এ.কে.এম. রফিকুদ্দিন আমরা যখন রাজশাহী মেডিকেল কলেজে ছিলাম তখন আমরা বিভিন্ন জিনিস নিয়ে চিন্তা করতাম। আমি সেই সময় যেহেতু আমি একটু লেস বিজি ছিলাম, আলাপ করে একটা পেপার খুব সম্ভবত পাবলিশ করছিলাম যে হোয়াট আর দ্য ইভেন্টস বিফোর হসপিটালাইজেশন ইন পেশেন্টস উইথ অ্যাকিউট এমআই। তার মানে ট্রান্সপোর্টেশন কিভাবে হাসপাতালে আসে, এত মজার জিনিস। কেউ নৌকায় আসে, কেউ ধান ক্ষেতের ভিতরে হেঁটে আসে, রিক্সায় আসে, সাইকেলে চড়ে আসে, কতক্ষণ তার পার হয়েছে হাসপাতালে আসার আগে। এবং এটা বিদেশের সাথে চিন্তা করলে, যে টেলিফোন করলো আর হেলিকপ্টারে নিয়ে গেল, আর বাংলাদেশে কিভাবে আসে চিন্তা করলে অবাক লাগে। 2 নম্বর হলো হাসপাতালের আসার আগে রুগীরা কি ওষুধ খেয়েছে। ইনভেরিয়েবলি তারা বিভিন্ন ধরনের পিপিআই, গ্যাসের ওষুধ, অ্যান্টাসিড, এগুলো বিভিন্ন জনের কাছ থেকে খেয়ে থাকে যে তার এটা গ্যাসের সমস্যা হয়েছে। এবং কে প্রথম তাকে বলছে যে এটা আপনার হার্ট অ্যাটাক হয়েছে, আপনি হাসপাতালে যান। এই যে বলাটা যে আপনি এটা যে বুকে ব্যথা হয়েছে, আপনি যেটা আপনাকে ইমিডিয়েটলি হাসপাতালে যেতে হবে, এই কথাটা কে প্রথম বলছে, এইটাও অনেক আমি দেখছি যে এটা জিজ্ঞেস করেও অনেক ইনফরমেশন পাওয়া যায়। তো আমরা আসলে হিস্ট্রি নিলে বোঝা যায় যে আমি কোথায় আছি, কার চিকিৎসা করতেছি। আরেকটা ঘটনা মনে হয় 4 বা 5 বছর আগে আমরা প্রায় 60-70 ডক্টরস, মানে এত সিনিয়র মোস্ট প্রফেসরই সবাই, তারা বগালেকে এক সময় আমরা গেছিলাম একবার একটা ঘুরতে, একটা বছরে একবার বান্দরবনে। সেখানে সেই এমন রিমোটেস্ট এলাকা, সেখানে আমাদের একজন সার্জারির সিনিয়র মোস্ট প্রফেসর যে আমার সাথে পার্ট 1-এ ছিল, আমরা রাতে একসাথে একই রুমে ঘুমাইছি। সকাল 9টার সময় ব্রেকফাস্টের সময় তার অ্যাকিউট এমআই হয়ে তার কার্ডিয়াক অ্যারেস্ট হয়ে গেছে। এমন ফরচুনেটলি দেখেন এবং আনফরচুনেটলি দেখেন, সেই সময় ছিল বাংলাদেশের একজন সিনিয়র মোস্ট কার্ডিওলজিস্ট এবং সিনিয়র মোস্ট অ্যানেস্থেটিস্ট, যারা সেখানে সিপিআর দেয় মাঠের মধ্যে ফেলে থাকে, এবং তার বোধহয় ফ্র্যাকচার রিবও হয়েছে। এবং ফরচুনেটলি সেই সময় তার আবার সার্কুলেশন শুরু হয়। একটু পরেই সে বলে যে আমার কি হয়েছে, আমার বুকে ব্যথা কেন। তার পরের বুকে ব্যথা হলো তার রিফ্র্যাকচারের জন্য। এবং তার সেই 9টা থেকে শুরু করে বিকাল 4টা পর্যন্ত 70-80 জন প্রফেসর মিলে তাকে একটা হেলিকপ্টার জোগাড় করা যায় নাই ওই পাহাড়ের উপর থেকে তাকে ঢাকা আনার জন্য। পরবর্তীতে 4টার সময় সেই আর্মির জওয়ানরা মিলে আরেকটা পাহাড়ের উপরে হেলিপ্যাডে যে একটা 4টার সময় একজন বাংলাদেশের নামকরা আরেকজন ইন্টারভেনশন কার্ডিওলজিস্ট সেই একই হেলিকপ্টারে তাকে নিয়ে এসে ইউনাইটেডে তাকে পিসিআই করেছে, এবং এখনো বোধহয় ভালোই আছে ইনশাল্লাহ আমার জানা মতে। আপনি তাহলে কত রকম ঘটনা ঘটতে পারে। আমি বলবো যে এমআই পেশেন্টের টিপিক্যাল প্রেজেন্টেশনের সাথে সাথে অনেক ধরনের অ্যাটিপিক্যাল প্রেজেন্টেশন থাকে। তো এই জন্য যে যেখানে থাকেন, মডার্ন চিকিৎসা পিসিআই সবচেয়ে ভালো। বলা হয় যে প্রতিটা মোমেন্ট, প্রতিটা সেকেন্ড, প্রতিটা ফার্স্ট আওয়ার গোল্ডেন আওয়ার। এই জন্য প্রথম পিসিআই করে ফেলতে পারলে খুবই ভালো। না পারলে কখন তাকে থ্রোম্বোলাইটিক থেরাপি দিতে হবে, কখন অ্যান্টিথ্রোম্বোটিক দিতে হবে, কখন কতটুকু তার লিপিড লোয়ারিং কতটুকু ডোজে দিতে হবে, এগুলো জানার শেষ নাই। আমি মনে করি প্রফেসর ওয়াদুদ চৌধুরী সাহেব আজকে অদ্ভুত সুন্দরভাবে এগুলো সবই বলার চেষ্টা করছেন। আমি সবাই আমার পারপাস হলো এসিপি থেকে আমরা I am capitalizing the knowledge experience of all senior teachers of Bangladesh so that we can disseminate this information, knowledge and experience of these learned teachers to all the medical students, residents, young physicians, consultants all over the country. একই সাথে আমাদের সিনিয়র দুইজন প্রফেসর মাহবুব মজুমদার এবং প্রফেসর ব্রিগেডিয়ার জেনারেল রাজ্জাক, আপনাদেরও ধন্যবাদ আপনাদের মূল্যবান নলেজ এক্সপেরিয়েন্স শেয়ার করার জন্য। ডক্টর পঙ্কজ এবং ডক্টর প্রিন্স, থ্যাংক ইউ ভেরি মাচ ফর ইউর গুড মডারেশন অ্যান্ড অ্যাঙ্করিং। আমাদের নেক্সট প্রেজেন্টেশন আবার নেক্সট থার্সডেতে একই সময় আমরা আবার চেষ্টা করব আরেকটা অ্যাকিউট মেডিসিনের একটা হেলথ টক নিয়ে। আমি আবার প্রফেসর ওয়াদুদ চৌধুরী আপনাকে ধন্যবাদ জানাই। থ্যাংক ইউ ফর ইউর ওয়ান্ডারফুল প্রেজেন্টেশন। থ্যাংক ইউ ভেরি মাচ অ্যান্ড all panelists and moderators. Thank you again and all listeners also.
Sadly, we have come to the end of today's program. We have learned so many important things about management of acute myocardial infarction from Sir today. Many thanks to the speaker, the chair, the panelist, and last but not the least, the moderator sir for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who asked very important questions. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole session on the YouTube right after the presentation finishes. Our next health talk on acute medicine will be held on 8th of September. See you all in the next episode. Until